So hello again. Let me call my colleagues on the panel. So I've got here Dr. Dhwani Patel, medical oncologist from Mumbai, Dr. Chandrakant, medical oncologist from Kolkata, Dr. Shantanu Pense, my colleague from Nagpur, Dr. Sumit Basu, radiation oncologist from Mumbai, Dr. Vasant Priya, she is also radiation oncologist from Mumbai, Dr. Shrigada Vivek Kumar, medical oncologist from Mumbai, Dr. Arav Tongavkar, medical oncologist from Mumbai as well. And obviously we've got our very experienced, chairpersons who I've requested to stay with us because, so these are, I know we're coming to the end and we are all hungry, so we will try to make it quick, but at least an appetizing session for all of us. So we've seen a few, very interesting abstract studies, findings. What it is just telling us that, the party has really begun when it comes to management of urothelial cancer. So all those, non-conventional, non-cytotoxic therapy that we have been using in other types of tumor are actually also coming into the foray into the management of the urothelial cancers. So what I'll do now, so our colleagues have kindly presented the data, okay, and we'll have an open discussion. I'll just ask a couple of questions and we can actually have an open forum on, if you want to make a comment, just make a comment on this. So Dr. Pense kindly presented on the first study, which was monotherapy pembrolizumab following trimodality of therapy. Now, can I ask our colleague Dr. Sumit Basu, radiation oncologist, please? Sir, how many patients do you think, I am actually quite interested to know about the trimodality. Do we think that all the patients who are eligible for trimodality do get trimodality of treatment with us? Because even Dr. Pense, you pointed out that not all of them had neoadjuvant chemotherapy. What is your take on that?
So, as you correctly said, all those patients who could be eligible for trimodality do not come to us for trimodality, that's for sure.
Okay.
So, what in my practice, what I have seen is that it's only those patients who are either reluctant or they want a bladder preservation given a clear option, or they are reluctant for surgery, or those who have comorbidities because for the surgical point of view are the ones who generally come to us and then ask as a radiation as a bladder preservation option. And so the number of patients who actually undergo trimodality therapy is few as compared to, what it should be ideally.
Okay.
So it is, it's not the absolute standard which is followed.
It is not, okay. And Dr. Dhwani, in your organization, I think you are from Tata, right? Do medical oncologists get involved early on in deciding whether this patient should have an intense trimodality, or is it only after the surgeons have refused that?
Sir, actually, all cases have been discussed in JC, in which we are actively participating. But yes, sir just rightly pointed out that patients, if they are reluctant or they are not eligible for surgery because of other comorbidities, then they are the main 70-80% of the patients who are. Those are the patients who are receiving trimodality treatment.
Okay. Sir, Nagaraj sir, your comment on, do we still, I think this is my opinion, that we in current practice, actually the urothelial cancer are completely governed by what our urosurgeon colleagues actually decide in some way, not maybe in large organizations, but that is happening in the community and even in the corporate hospitals.
That's why I said I think there are quite a few there's quite a bit of churning that's happening, and Pembro is fairly recent, and trimodality is, I don't think, still is a very popular approach that I see even in private sector.
Okay. Now, Dr. Vasant Priya, do you have any comment on the data that we saw? Because Dr. Pense is very clear that this is not a practice-changing trial in spite of, these PFS, OS data at though it is at 1 year. Any comment on what would you do? You think it's practice changing, or we have to wait or do something else?
Sir, I don't think it's practice changing because only 10 patients have completed the entire cycle of pembrolizumab.
Yeah.
So we have to wait for the updated results, some 5-year data for that.
And Dr. Payne said, what would it take for you to actually be convinced that this may be efficacious? What would you like to see? Do you want to see a change in design? Do you want to see something different coming out of this? Do you want more numbers?
Sir, everything. More number, comparison, comparative arm to it. Secondly, higher risk patients, at least N1, if not N2.
Okay.
And T3. This trial did not have any patients of T3, T4 as well. So
Okay.
it is purely T1, T2, where patients have been selected.
Dr. Tongaonkar, you want to say, comment some?
Just an added input, sir. With a larger number and a longer follow-up, we also need to see the rate of salvage cystectomy is required. Are we really able to preserve the bladder better by giving pembrolizumab? It's not only about survival. So if the intent was bladder preservation, is pembrolizumab contributing to that?
And preservation when? Suppose if your recurrence happens 4 years down the line, it's okay. So that's duration is also important.
Exactly.
Disease-free survival is important.
So, Dr. Chandrakant, how many patients do you think should we offer bladder preservation if they are eligible? It's an obvious answer, but
no. In the present, the data is more pronounced for cystectomy, pre-operative.
Yeah.
Niagara was the trial. So this data looks interesting. Like. We are looking for preserving bladder, and that is really good. So, if someone opts for trimodality therapy, then not doing cystectomy and following them up in this way, and the 5-year survival is something above, 1 year survival is above 95%.
Yeah.
So, yes, we have a data where if someone is not willing for cystectomy or not eligible for cystectomy, trimodality therapy followed by this surveillance and giving pembrolizumab in this patient is attractive.
Yeah, you're right. And what I feel, sir,
we used to observe post trimodality, and here we have some role of pembrolizumab, and even in non-muscle invasive bladder cancer where BCG refractory, not willing for cystectomy, there is data for pembrolizumab. So this can be practiced in patients who do not opt for cystectomy.
So see, Dr. Nagendra, your take, because I personally feel, sir, that having a bladder removed is not a very, it's not a normal surgery. It is like none of the surgeries are normal, but especially when it comes to the quality of life and functionality. So I think this is leading us to actually try and preserve the functionality of the patient, even though the data may be, not as convincing. What is your take on it?
Absolutely right, sir. So getting a cancer diagnosis and going through his treatment is not only devastating for the patient, it's actually devastating for the entire family, right?
Yeah.
And the challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. The point here is when we are going for a bladder preservation approach,
Yeah.
and those patients who are selecting that, right? Because this is not ideal, but if those patients are selecting and we are having something to offer down the line and which have shown amazing data like that 1 year, although the point there is only 10 patients are able to complete that, 17 cycles.
Yeah.
That's a very important point. The limited number of patients were taken into consideration. We can do, this is one step in right direction, but maybe possible in next couple of years when the trial is more mature and the phase 3 trial also come in this scenario, then we'll be able to answer better. But yes, this is one step in right direction.
Okay, I'll come back to this trial in a bit for when I ask a particular question. But let us now move on to the next, two posters that were presented, and I'm going to ask Dr. Shrigada Vivek Kumar to actually comment on what he felt about this one. This is basically a meta-analysis review, actually, systematic review.
Yes, sir. The thing is, this is most of this, the trials which include in this are retrospective. As we know, the NACT, it showed OS benefit especially with DDM back and even with GEMSIS, and the Niagara showing there is a EFS and OS benefit. I don't think NACT is not that benefit which is been quoted in this trial.
Okay, but can I ask Dr. Shantanu then, meta-analysis and review, level 1 evidence, That is what we used to say. Do we still want to actually say that in spite of having 3,354 patients, we are not convinced by the data? What do you think? Should we actually, how do we poke holes in this? So they've given us a clue already. Anyone wants to comment on this?
The author's conclusion seems that they themselves were not convinced with the data. They've given a kind of, disclaimer that it was a retrospective low quality data, which is unusual. So probably the fine tuning, the data collection from the trials which were included in the meta-analysis may have been suboptimal.
Yeah.
So on a case-to-case, maybe meta-analysis are good for a broad perspective, but on a case-to-case perspective, when we want to treat that patient who's sitting in front of us, it would be a clinical decision more than the meta-analysis driven decision.
Okay, sir.
Yeah, actually, as it was pointed out by Amol who presented this, that both these papers were retrospective.
Yeah.
So probably, because see, neoadjuvant we know definitely has a benefit in bladder.
Yeah.
Now, when we talk about cystectomy. So from there, I mean, probably there should have been some benefit that was expected, but with such a huge data, meta-analysis still has not shown any benefit. Probably if we do a randomized control trial, and we might get something, out of it, possibly.
Yeah. So what I felt when I was just going through this, that we want a huge data, but that might be a problem here, because if you look at all the trials, we have trials that have changed practice based on 70 patients, 80 patients. To collect this many patients, they would have had to go to very long back in past. The treatment modalities, the skill set and other things would have changed. But they have also pointed out at this wonderful tool, the Robbins 1 tool, that the Cochrane has actually promoted as one of the main tools to actually do meta-analysis. What I think they found that not just this data analysis, but even those studies that they were analyzing had a bit of a kind of lacunae, and they did not stand the test of this tool. So, in contradiction to this is just a few highlights that they have said. This is just why they did not feel that this was a good data.
Do we routinely give neoadjuvant chemo post before CTRT in bladder if it is? So then this trial is not relevant.
Yeah, and this one, you think this one is not relevant at the moment? Not. So let's forget. So let's look at the future. Let's look at, we are trying to do whatever it takes to preserve bladder. Let us see if this is setting the stage for something new and something big. Is there anyone wants to comment on whether?
I think the strategy is working in many sites, be it now, head and neck, bladder, and many other sites. So I think, and there is some data, and retrospective analysis need not be just dumped onto it has its own relevance. It's fine.
Yeah. So I think it is.
As I understand that, but then retrospective studies like this, sites wherein followed by CTRT. So you evolve a certain paradigm, and because
do you think this is at least hypothesis forming?
No, I would go more than that.
You would go more than that.
So this trial is saying if I do neoadjuvant chemo followed by chemo radiation, there is an impressive overall survival benefit.
Yeah.
But we don't know whether NAC is acting or CTRT is contributing to it. What is contributing to it? We really don't know the differential benefit of each of them.
So I think, sir, this answers a slightly different question for me. We have a lot of patients, we start with a neoadjuvant chemotherapy and they've been counseled for cystectomy, get a very good response, and now they want to preserve the bladder. So I think with this trial data, at least we could reassure them that the radiation, in that situation, switching to CTRT and a bladder preservation approach may be feasible.
I don't see many surgeons keep cystectomy at the end, offer a bladder sparing.
Okay. Okay, you know what? Let us look. What my thought is, this is hypothesis forming. Like you are saying, this is setting the stage for a potential trial for patients who may not be eligible for cystectomy or who may opt not to have cystectomy. Whether just it is because this is just about chemotherapy, I'm very certain that biologicals are going to come into this picture as well. So I personally feel this is setting a stage for something different in future. So now we move to the next presentation, which is the study and efficacy of neoadjuvant durvalumab in combination with GemCis or GemCarbo. Now I have one question for everyone. Are we all convinced cisplatin is better than carboplatin in bladder? Because this is a debate that, you know, and my colleagues from Tata are always very emphatic that cisplatin, this is my observation, okay? Do we think they are that different? Is that the current, you know, experience in the clinical world?
I think in urinary bladder cancer, yes. In upper tract, something different.
Upper tract, something different you feel. Okay. What about you, Dr. Nagendra? What do you think?
Absolutely right, sir. For especially those patients who are young and fit and who are cisplatin eligible, it's always better to use that drug. But there are some things which you have to keep in mind, because we have to give large volume of fluid with that. Patients having cardiac morbidity, which can be counterproductive, right?
Yeah.
So in that, or backs are pushed against the wall. In that case, carboplatin have to be used. But in a scenario in which patient is young, fit, no comorbidities, I will be opting towards GemCis.
Okay. A patient with cardiac failure, okay, or, you know, poor ejection fraction, and a potential, you know, cardiovascular issue. Would you be happy just to replace carboplatin with cisplatin, or do you think that is not the right drug at all? You'll just go for single agent gemcitabine.
So after the Niagara trial, the eligibility of cisplatin is little relaxed. Even a lower GFR, we can offer 75% dose of cisplatin. So somehow, you know, cisplatin is for urinary bladder. So this is the notion that we have developed. In fact, if you do a surgery, a cystectomy upfront, and patient is not cisplatin eligible, guideline says give immunotherapy. Don't give GemCarbo in a urinary bladder. Whereas for upper tract, you can give GemCarbo. This is based on what she presented.
Okay, interesting. Dr. Srigadam, what do you feel about, you know, this trial design? You think because they were adding durvalumab, they wanted to try the carboplatin even though we know the cisplatin seems to be doing better?
Yes, sir. But the thing is, they randomized, I mean, they allotted the patient to carboplatin who are ineligible for cisplatin. So in that sense, it's okay.
And does anyone think that would have changed the outcome also? Because they are using patients who are ineligible for cisplatin, means they might have some other ongoing comorbidities. What is...
If it is creatinine, then we can go ahead with the Niagara, like day 1, day 8, if it is less than 60.
Yeah.
But they didn't exactly mention why the patients are ineligible for cisplatin in that abstract.
So, you know, when I was presenting my initial Pembro data, so there are really 3 or 4 good prognostic tools. One of them is Belmont tool, which is looking at the hemoglobin liver metastasis. There are other tools looking at CRP and other organ functions. So my thought when I was reading this was, you know, if you're randomizing, you have to randomize, you know, not based on the clinical characteristic, but everyone should go into it. But in this case, it would have been difficult. Maybe they would have had to randomize all cisplatin eligible into cisplatin versus carboplatin to actually truly see whether it works at all or not. Then obviously there is nothing to say about, you know, the toxicity profile is not very different. But Dr. Tongaonkar, with the outcome and the data, yeah, would you adopt this in the practice, or would you think that a larger trial would help us adopt this in the practice?
A larger trial would always be more helpful, sir. Just not totally convinced about carboplatin in the neoadjuvant setting. So just because we're adding an immunotherapy and it has given a decent result, we may be denying the patient a standard of care therapy. I would be interested in the primary progressors in that arm, because those patients by definition would have been eligible for upfront cystectomy.
Yeah.
But because we have given maybe an inferior neoadjuvant therapy and they have progressed, then are we really going in the right direction?
Okay. I'm going to ask Dr. Vasant Priya about, you know, what would you think of if we are giving this regime and then the patient requires radiotherapy. They're going for, let's say, the trimodality after NAC, but we have given them durvalumab. Will that affect what you decide, the doses you give, or will it not affect at all?
No, sir, it will not affect the dose we prescribe.
You don't,
No.
you don't think. And Dr. Basu, any change in the efficacy of radiotherapy if we give upfront immunotherapy?
I don't think so. Although we don't know, still not very clear. But I don't think so. We probably it should work as well. In fact, it should work better. I mean, let's not go into that. But with SBRT and immuno combinations and all that's a different thing where probably there is a synergistic thing out there.
Yeah.
But we will give a standard radiation. SABR boost, there was a topic discussed. We are not doing it routinely that way, you know. So we generally do whole bladder only as of now.
Okay.
And we don't really give a SABR boost, but that's also a novel thought if we are combining with IU. Yeah.
I just a point. I think there was a subsequent paper which said that 12% patients were not positive. So that was one of the challenges of SCT. I think that should be discussed along with this paper.
And sir also asked about whether the chemotherapy, immunotherapy or radiotherapy has an impact on the immunotherapy. Okay, now I want to ask our medical oncology, just one comment each. Do we believe in hot tumor, cold tumor?
Yes, different tumor types have different behaviors based on the immune reactivity at least. We don't have a very good marker, but it's a good gray area.
Yeah.
Yes.
Now, anyone else? Any comment on hot tumor, cold tumor?
Not everywhere, sir, but the data has come in breast as well.
Yeah. So the reason I ask you that is just corollary to sir's question. Do you think chemotherapy or radiotherapy can make the tumor hot?
Sir, pertaining to this question and previous as well, even the immunomodulatory effect of cisplatin and carboplatin have been shown to be different. So as Dr. Arnav said before, offering durvalumab with cis and offering durvalumab with carbo is likely to be a different therapy altogether. It is an under treatment probably durvalumab with carboplatin. And so some drugs, yes, not necessarily in every tumor, not necessarily with every drug.
Just to stretch that question, Basu, I mean, do you think hypofractionation or what should I say, SBRT, etc., are more relevant in making cold to hot, or conventional fractionation is also?
Probably yes, sir. Probably yes.
So
I'm not very sure, but
there was a trial presented in ESMO, which actually succeeded in proving that some fractions of radiotherapy to breast actually makes the tumor more immune reactive or responsive to immune therapy. I forget the name, it's a small trial, but they are actually doing a follow-up on that. And like you were just mentioning, see, we medical oncologists, we like to believe, we believe that one day we will get rid of all the cytotoxics. We will only be using the biologics. But what we have realized is that all these drugs, none of the drug have just one function. Even though we study it's a cell cycle, it affects this phase of cycle, but they have a lot of contributory factors. It's the cancer microenvironment, tumor microenvironment that actually is modulated. And like you were saying, each drug has a different action. So I think in some shape or form, even for example, the load metronomic therapy that we use for cyclophosphamide and methotrexate, it is not cytotoxic. It is the immune modulatory effect we are trying to enhance. So that might actually also explain why one drugs work with immunotherapy and another drug does not work with immunotherapy.
And this change of microenvironment thing, probably whether it is SBRT which is doing it for the immuno or immuno doing for what, I mean, again, that's not very clear. Probably it's a vice versa thing.
Yeah.
It's both ways actually.
Okay.
Conceptually, yes, it is. Yes. It is definitely there. Yeah.
Yes, you're right. I know it's it ticks our brain. It's a good academic exercise, and I'm sure we will be able to. We'll see. Now let's move on to the POUT trial. Okay, I don't think anyone of us disagree with the robustness of the data. If you do, just let me know. Dr. Shrigada, please. Are you convinced with the data?
Yes, sir.
And the design and everything?
So the standard till POUT, the standard is observation after surgery. About now it's practice changing. We are using adjuvant therapy.
Dhwani, what do you think?
Yes, sir. It is practice changing. We are using adjuvant gem, cytarabine, cisplatin. The only thing after nephroureterectomy, the GFR and the single kidney function will be there. So they have included patients with low GFR and given carboplatin also. So that is like either gemcis or gem carbo. We can use both.
Okay, so things here are a bit more open to use of carboplatin. Someone, I think whether it was you or you, I don't remember, you pointed out the challenges of that are different for upper urothelial tract cancer.
Yes, sir, because in this background of this trial, they have said that in one of the retrospective series that 12% of the patients who underwent nephroureterectomy found no tumor at all. So giving neoadjuvant is the problem in the upper tract urothelial cancer.
So if you have a suspicious lesion somewhere in the ureter, upper ureter or renal pelvis, and
if it is operable, then surgery is the
and the patient has several comorbidities. I'm giving you a real case. Okay, I had a patient, 80-year-old man, ejection fraction of 30. Okay, chronic kidney disease, performance status of 2, on a routine investigation ultrasound because of abdominal pain, had a lesion in the renal pelvis. Now
so we can do urine cytology if it is positive.
Exactly,
then,
and that is beautiful, because that is what I did, because this patient was wandering from pillar to post from different hospitals, meeting several. So the patient waited for 4 months until they came to me. Went everywhere. They said, "Oh, let's think of how to do a biopsy. Let us do this. Let us try. Maybe we can do. I just do a radiotherapy empirically." Sir,
you think CTC would be useful?
CTC, yeah. So I gave her 2 options: CTC, ctDNA, and urine cytology. With the cost, the patient went to urine cytology. Sir, my question to you, and this is one of the big reason I wanted you here, is: do you think we are losing touch with the basic and just going for the ctDNA and not looking at the basics like CTC? Why are we not? What do you think?
Early days for CTC, isn't that? I mean, I would think that way. I'm not still gung-ho about that.
And urine cytology, why are we not using urine cytology as much as we should?
Yield is poor. Yield is poor. So
yield is poor.
Yeah. Okay. Actually, there is almost 20 to 30% of discordant between the biopsy and the urine cytology. Even especially with if it is biopsy showing high grade, the urine is showing low grade. So if it is possible, we can do both.
Yeah, that's true. But one of the things what I think most of the guidelines support, that you don't do just one urine cytology. You do a subsequent. It's a sequential thing. But that is what I feel as medical oncologist is an underutilized thing, because basically it's similar to CTC but just in a different fluid. So
in the previous study which you showed, gemcis durva or gem carbo durva, 50% patients didn't undergo biopsy.
Biopsy.
They took directly neoadjuvant therapy.
Wow. So that was
based
an
radiological
based on the MDT discussion.
In that trial, they have done urine cytology also. Like the
in this trial?
Previous
in the previous trial.
Interesting. And then the yield was poor.
No, the yield was good, but there is a discrepancy between the grading of that. It's high grade in biopsy or in the histopathology, but it is showing low grade in cytology.
Yeah, what I feel is, see, it may have a very low sensitivity, but it definitely has high specificity. Once you got positive, you know what it is, then you can decide, because that is another question of what do you do with it. Once you have the diagnosis, because it is so rare, it is very difficult to actually have good experience unless you are working in a larger center.
So I just want to know, like, are we there yet that we have to do the NGS also in locally advanced setting or urothelial cancer? Why I'm asking is, the durvalumab is used with the platinum drugs, and if we are having FGFR mutation positive or HER2 expression is there by IHC, so we are having a trial of phase 2 in which Enfortumab Vedotin, as the antibody drug conjugate, is used with toripalimab in the neoadjuvant setting, and then the patients were having a better pathological CR. So now the question is that we should do this molecular testing upfront in locally advanced or early stage also, or because durvalumab we are using. If we are having external mutation, we should not use durvalumab, right? So are we there yet? Chandrakant?
Up to now, I agree. I mean, doing NGS in an early locally advanced stage still evolving, but I agree in future this would come up. But as of now, we are not doing NGS in a locally advanced setting. Yeah, but I agree with you. In future, probably this may come up.
So some data regarding adjuvant erdafitinib for FGFR expression is also coming up. So we should do the NGS in locally advanced.
It stands to logic, and it will be, we will be there yet, not yet, but in future it will be, it's the way.
So we've got just little less than 2 minutes. I'm just going to stop with my favorite trial, Tambola trial. I think we discussed it at the best of ASCO also, and I'll have everyone can have a go at what do you feel about the Tambola trial, what do you think it means, and where are we going with this in future? You can start with Dr. Shrigada.
It is good. We can do ctDNA follow-up, but the thing is, most of the patients anyway end up proving that there is a disease by doing biopsy or imaging at the end of the day. So, as of now, it's not that. And the cost, like all of us know, it's not possible in our setting.
What do you think, Dr. Penson?
So, should help. ctDNA should help more in de-escalation post-neoadjuvant bladder. It may, likely to be present at this Niagara data with ctDNA in ASCO GU, but currently it may turn out to be lead time bias or anything. So yes, we have definitely proof to offer something based on ctDNA. I won't.
So if you're talking, it's a very European view to actually think of de-escalation. If I ask an American, they will say that there will be more patients who will become eligible for therapy. What do you think?
Agree. So I gave Niagara, GEMS is Durva 4 cycles. I did cystectomy, and ctDNA is negative. So then if a patient is not eligible or not willing for Durva, in those patients I can apply it. But if it is positive, my treatment won't change. I would continue durvalumab only. So this is what. So I agree. So now ctDNA is predictive.
Yeah.
If I give more immuno, it is becoming negative. That means yes. So there is some data that immunotherapy is converting the ctDNA in positive to negative over a period of time. A longer follow-up is required, but yes, adjuvant IO is working.
Wonderful.
Sir, we need more data. Actually, if the ctDNA is positive, then what to do? To continue with the same therapy or to switch the therapy? That is the main concern.
Dr. Basu, any word on this?
Not really, not really. But I think, whatever, I agree to whatever they're saying, practically.
So we are running out of time, but see, now let us think of the tri-modality trial. What if we had started doing ctDNA for those patients? What do you think? Dr. Tongaonkar.
Good marker, like everyone said that it has a good negative predictive value. If you are achieving ctDNA sterilization, most of those patients are not relapsing. So there we know that we probably have done enough for the patient. And just an added thing, so here we used atezolizumab at the time of ctDNA positivity, but probably most of our patients will not afford an immunotherapy even at the time of relapse. So another thing which we could design in our setting is if you're even monitoring ctDNA, seeing if even conventional chemotherapy has a similar sort of tumor sterilizing effect before there's a clinically apparent disease.
Okay. So I'm going to ask Dr. Nagaraj to give a final word or final comment on where he thinks, based on this, where we are going in management of urothelial cancer.
Same thing. I think there's a huge flux. The paradigm changes. Jury is out.
Yeah.
We had a lovely discussion.
Okay. Thank you so much. Thank you for your time.